Good morning, one and all present here. Today, we'll be talking about nutritional disorders. Nutritional diseases occurs when there is an insufficiency of energy. So basically, an adequate diet should provide sufficient energy in the form of carbohydrates, fats, and proteins. Vitamins and minerals, which function as coenzymes or hormones in vital metabolic pathways, or as the case of calcium and phosphate, as important structural components. The main disorders are obesity, kwashiorkor, marasmus, anorexia nervosa, bulimia nervosa, vitamin deficiency, trace element deficiencies. Malnutrition. The World Health Organization defines malnutrition as the cellular imbalance between supply of nutrients and energy and the body's demand for them to ensure growth, maintenance, and specific functions. Primarily, it is related to the diet, and secondarily, it may be related to nutrient malabsorption, impaired nutrition utilization or storage, excess nutrient losses, increased needs for nutrients. Protein energy malnutrition. Inadequate intake of proteins and calories. It may lead to two syndromes, marasmus and kwashiorkor. Marasmus is starvation in infant with overall lack of calories. Somatic protein compartment, that is, the skeletal muscles are affected. Whereas in kwashiorkor, protein deprivation more severe than the deficit in the calories. There will be sufficient amount of calories, but the deprivation is more. Visceral compartment, protein stores in the liver which are affected. The visceral compartment is affected. Marasmus. Marasmus is a consequence of protein energy deficiency, which is characterized by wasting of muscles and fat tissues. The skin and the bone are involved and may lead to growth retardation. Serum protein is normal and there is no edema. It can occur at any age and can be easily compensated by normalizing nutritional supply of proteins and other nutrients. The clinical features are weight is less than 60% of the normal, loss of muscle mass and subcutaneous fat, which leading to emaciation of the extremities, and the head appears too large for the body. Usually, there is associated anemia, multivitamin deficiencies, and immune deficiency, which leads to T cell immunity deficiency and concurrent infections. Kwashiorkor. Kwashiorkor is a childhood protein energy deficiency that occurs when protein deprivation is greater than reduction in total calories. Typically, it occurs in children who have been weaned off the mother's breast milk and when they have a second child was born. The clinical features are hypoalbuminemia and generalized or dependent edema. Loss of weight masked by edema. Usually, there is sparing of muscle and the subcutaneous fat, and weight is between 60 to 80% of the normal. Other clinical features include flaky paint appearance of the skin, altering zones of hyperpigmentation, and areas of desquamation and hypopigmentation can be seen. Alternating bands of pale and dark hair, that is called as flag sign, then enlarged fatty liver, atrophy and loss of small intestinal villi leading to concurrent loss of small intestinal enzymes, that disaccharidase deficiency, development of apathy and listlessness, loss of appetite, other vitamin deficiencies, and defects in immunity. This picture shows the difference between marasmus and kwashiorkor. We can see the pictorial difference where we can see the complete emaciation in case of marasmus, whereas in kwashiorkor, chubbiness is there, but still the patient suffers from protein energy malnutrition. Now we'll see on to the difference between kwashiorkor and marasmus by clinical feature, morphology. So the clinical differences are kwashiorkor occurs in children between 6 months and 3 years of age. There will be growth failure, wasting muscles, but preserved adipose tissues will be there. Edema, localized or generalized, but it is present. Enlarged fatty liver can be seen. Serum protein levels are lower. Anemia is present, and alternate bands of light and dark hair, which is called flag sign. Whereas in marasmus, which is common in infants under 1 year of age, growth failure can be seen, wasting of all tissues including muscles and the adipose tissues. Edema is absent here, no hepatic enlargement, serum proteins are normal, anemia is present, monkey-like face, that is protuberance of the abdomen and thin limbs are seen. The morphological differences in kwashiorkor, enlarged body liver, atrophy of different tissues and organs, but subcutaneous fat is preserved. Small bowel, mucosal atrophy and loss of villi and microvilli can be seen. Bone marrow hypoplastic, cerebral atrophy, thymic and lymphoid atrophy are seen. In case of marasmus, no fatty liver, atrophy of different tissues and organs, including subcutaneous fat, can be seen, which is rarely seen. Hypoplastic bone are seen and it is less marked. Again, a graphical representation of kwashiorkor and the marasmus and its presentations. A picture of marasmus affected child. Now we saw predominantly protein energy malnutrition in children. Those that happens in the older age, it is called as secondary protein energy malnutrition. So this develops in chronically ill, older and bedridden patients. The obvious signs of secondary protein energy malnutrition include depletion of subcutaneous fat in arms, chest wall, shoulders, or metacarpal regions, wasting of quadriceps and deltoid muscles, ankle or sacral edema can be seen. Cachexia, protein energy malnutrition in patients with AIDS